You want to check whether the voice is okay or not. The stream is there, but I'm not sure about the voice. Can anyone of you please let me know if I'm audible? Because I can see the stream, but I cannot hear my voice as of now. Working, 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 working. Can I get a glass? Just to have a glass of water. I don't notice any kind of lag. Open it right here in front of me, so that I'm able to get to see it like what is happening around. Thank you. Gee. Okay, right. Now I get to see. Now I get to see you people, so that makes me alive. That makes me alive. Whenever I see you guys, that makes me alive. Okay, right, buddies. No time to waste. We have to revise the entire orthopedics as of now. So this is Dr. Nitin Bhagat, right? Orthopedics faculty at Meduhub, right? I'm teaching FMGs for around 15 years as of now, right? So this day, we have got a little around 2.5 to 3 hours, right? And this 2.5 to 3 hour, we will try to cover as much of orthopedics as possible. As much of orthopedics as possible, we'll try to cover in these 2.5 to 3 hours, right? So we'll start with this first topic. And this first topic happens to be a random topic from the orthopedics, that is scurvy and other diseases, like some other diseases like osteopetrosis. And meanwhile, I can see your comments right in front of you. If there is anything to ask you, please feel free to interrupt. And after this class, I will share this PDF. I will definitely share this PDF. So this scurvy, there is another name. Scurvy is also known as Barlow disease. And in this class, almost 70 to 80% is already written. I need to write few words here and there, very few words here and there. Let me shift it to a better internet. So I need to write very few words. That saves plenty of our time. Okay. Now, what age group it affects? So it basically affects children and elderly. Children and elderly. Children, poor diet because of they eat lots of fast foods, and they are more dependent upon milk. And elderly, because they get very little to eat. After one or two chapati, they will say, oh, I don't feel like eating. Bas ji bahut ho gaya, bahut kha liya, right? So they don't feel like eating. Okay. It's common in alcoholic, their only focus is on drinking and not upon eating. And in smokers. Okay. Right. Now, cooking destroys vitamin C. That means heat destroys vitamin C. It doesn't develop in the first 6 months because, milk has vitamin C. Maternal, uh, you know, the mother's milk has got vitamin C. Now, male female incidence is nearly equal, right? Male female incidence is nearly equal. Now, what is the problem here? That humans, they lack this enzyme gulo. Fine. Gulo, gulono, lacton oxidase. So they cannot make their own vitamin D. They can not make their own vitamin C. Right. Now, That is why, there is increased tendency of bleeding, increased tendency of bleeding. Remember, if I ask you that, okay, what are the clinical features of vitamin C deficiency, the first thing that comes to your mind is gum bleeding. So there are chances of bleeding. So here in scurvy, what is the first thing which you notice? Subperiosteal hematoma. This periosteum, that incidentally happens to be very vascular structure, very vascular structure. So there will be bleeding, and because of that, what will you notice? That the periosteum is elevated, that the periosteum is elevated, periosteum is elevated, right? Okay, then another thing which you will notice here is pencil pencil point cortex, pencil point cortex. You see here, let me go back. Now see, this outer part, this is cortex, and incidentally cortex will be very thin. That is why we call it pencil point cortex. We call it pencil point cortex, pencil point cortex. Okay, right. Now we get to see this white line of Frankel, this white line of Frankel, white line of Frankel. Now, what is this white line of Frankel? That is zone of calcification. Why the zone of calcification? Because you see there is no deficiency. There is no deficiency of calcium. There is no deficiency of calcium. That is why there will be calcification. That is why there will be calcification. Fine. Now see. So here. Now you see. This is white line of Frankel. Below the white line of Frankel, there is a dark black area. There is a dark black area. Fine. This is called as tremor felt zone. Tremor felt zone. Tremor felt zone. So, transverse, lucent. Lucent mean this will appear black. This will appear black on X-ray. This will appear black on X-ray. This will appear black on X-ray. Fine, lucent areas will be seen. Right. Now, what else do you get to see here? You else get to see heme arthrosis. Heme arthrosis. Heme arthrosis means collection of blood in the joint. Collection of blood in the joint. Now, in clinical questions, you will see this line. Boggy swelling of the joint. Ekdam pilpila sa, right? Boggy swelling of the joint. That is heme arthrosis. Heme arthrosis. Okay. Now see this sharp area. Right. This sharp area, rough area, sharp area. This is called as Falcon spur. This is called as Falcon spur. Fine. Now what do we get to see Falcon spur? So Falcon spur, it is seen due to healing of micro fractures, due to healing of micro fractures, right? Falcon spur. What are Falcon spurs? Falcon spurs are rough areas in metaphysis, rough areas in the metaphysis. Falcon spur, Falcon spur, right? Okay, so these are the common important question which they ask about scurvy. Common important question which they ask about scurvy. Are we missing something? Yes. Now see this Wimberger ring sign. Wimberger ring sign. Fine. Now Wimberger ring sign. You see here. This is epiphysis. E stands for epiphysis. This one is metaphysis. So Wimberger ring sign. See here. This is what we are talking about. Wimberger. This which I have shaded yellow. ये रहा जी. लो जी. Wimberger ring sign. ये जिसको मैंने अभी पीला शेड किया. The one which I have shaded yellow, Wimberger ring sign. That is zone of calcification. That is zone of calcification around. Wait. Okay. Is it? Yes. So that is zone of calcification around epiphysis. Zone of calcification around epiphysis. So Wimberger ring sign. That is what? Okay. Calcification. Wait. So Wimberger ring sign is calcification around epiphysis. Is it stuck? Stuck at my phone. It's working, right? There's some problem in my phone. Okay. Now, the next thing which we are going to discuss is another important topic, and that happens to be fibrous dysplasia. Fibrous dysplasia. Fine. So, fibrous dysplasia, it is a genetic disorder where what happens is there is failure to form mature lamellar. Lamellar means bone in layers, and the bone is arrested as a woven bone only. Bone is arrested as a woven bone only, right? Now it is usually sporadic. Sporadic means there is no family history. There is no family history. But you know, this may also be associated with McCune-Albright syndrome. McCune-Albright syndrome. McCune-Albright syndrome, right? Okay, so it is of two types. Monoostic. Monoostic means a single bone is affected. Single bone is affected, right? So here, most common bone affected are the ribs. So usually, one single rib would be affected. Usually, one single rib would be affected. Okay. Then polyostic bone. Polyostic disease, that means many bones are affected. Many bones are affected, right? Now here, okay, what is the important thing for you to notice here? The important thing for you to notice here is Shepherd crook deformity. Shepherd crook deformity. So you see here Shepherd crook. This is Shepherd crook. Shepherd crook. ये रहा जी. Shepherd, भेड़ बकरियां चराने वाला. Shepherd crook. Crook जो उसके हाथ में डंडा रहता है. That is crook. Shepherd crook deformity. Shepherd crook deformity. Right? Now here, treatment would be nutrition and surgery. So just improve the nutrition and some of yes, Dr. Dr. Jovita James. I hope I pronounced your name correctly, right? Shepherd cook. So if you ask me what is important thing over here, the important thing is just this image. Just this image, that happens to be an important one. They ask about this very often. Whether it is NEET PG, whether it is FMGE, that happens to be their favorite image-based question. Shepherd crook deformity. Shepherd crook deformity. Right? Now, with this, we move to the next topic there, and that next topic happens to be our osteoporosis. Osteoporosis. Right? Now, you see here, osteoporosis. So you see, it is of two types. Primary. So primary again is of further two types. Primary osteoporosis, that means there is no other disease. There is no other disease. Secondary osteoporosis means some other disease, some other disease, some other drug is causing osteoporosis. Some other disease or some other drug is causing osteoporosis. Fine. Now, so once again, very quickly, the different type of osteoporosis. You see, primary osteoporosis, secondary osteoporosis. Primary osteoporosis is of, that is why type 2 osteoporosis, this happens to be the most common type. This happens to be the most common type of osteoporosis, most common type of osteoporosis, right? Now, secondary osteoporosis, most common cause, that happens to be steroid use. Most common cause happens to be steroid use. Steroid use, right? Now, the next thing here. Other causes: rheumatoid arthritis, ankylosing spondylitis, hyperparathyroidism, and thyrotoxicosis. You see, these are all the causes. These are all the causes of secondary osteoporosis, right? Peak bone mass, it is seen between 25 to 30 years of age, and after that it declines at the rate of 0.5% every year. There is no voice. Is it the same for everyone? Dr. Varun Thakur Saab says that there is no voice. Are you sure? Let me check, because here you see on my phone it says that there is voice. Is it the same for everyone? Declines at the rate of 0. नहीं ठाकुर साहब, इस पे तो आ रही है आवाज. हाँ जी. Dr. Thakur ji, just switch the YouTube off and then switch it on. It's working now. Yeah, it is working. Right. हो जाता है कई बार जी, हो जाता है. Right. Okay. Now, what are the clinical features here? What are the clinical features? So clinical features, they will be bone pain, but naturally they will not ask you about this. Clinical features are joint pain. Fine. What is this clinical feature? Can anyone tell me the name of this clinical feature? So this clinical feature, this happens to be Dowager hump deformity. Dowager hump deformity, bending forward, Dowager hump, right? Now, so what actually happens is we get to see something called as cod fish vertebra, also called as fish mouth vertebra, also called as fish mouth vertebra. So what happens is normal vertebra, they are like this, fine, normal vertebra, and this is the intervertebral disc. What happens is when the bone mass is lost, these vertebrae, they become like this, they become smaller, right? Now this area between them, sorry, now this begins to appear like fish mouth. This happens to be the fish mouth vertebra. Unfortunately, these changes are only seen when 30 to 40% of the bone mass is lost. When 30 to 40% of the bone mass is lost, fine, and bone is prone to fracture. Fractures become very common. Bone is prone to fracture. Bone is prone to fractures, right? Okay. So that is why we need better investigation. We need better investigation, right? So what is the better investigation? DEXA scan, dual energy X-ray absorptiometry, dual energy X-ray absorptiometry. Fine. So it measures bone mineral density. It measure bone mineral density. Fine. Now what we will do is we will measure bone mineral density with healthy will measure bone mineral density with healthy individual, right? Now, so we get to see two things: T score and Z score. T score and Z score. What is the purpose of T score? So T score, when bone mineral density is compared with race and gender matched younger individual, at that time we get something which is called as T score. Now, next is Z score. Z score, when bone mineral density is compared with race, gender, and age matched individual. For example, your patient is 60-year-old Indian male. When you compare the bone mineral density of your patient with bone mineral density of 25-year-old Indian male, you will get to see T score. Now here, your patient again is 60-year-old Indian and male. When you compare his bone mineral density with a 60-year-old Indian male, you will get to see Z score. So Z score is not important. What is important? T score. What is important? T score. Fine. Now here, so we'll get to see bone mineral density. So T score -1 to +1, that happens to be absolutely normal. -1 to -2.5, that means your patient has developed osteopenia. And -2.5 to -4, that means your patient has developed osteoporosis. So when the T score is less than 2.5, we will say that your patient has developed osteoporosis. Your patient has developed osteoporosis. At that very time, we will say that our patient has developed osteoporosis. Fine. Now, what are the different drugs? What are the different drugs? Fine. So the first drug here is bisphosphonate. Bisphosphonate. What different drugs? So you see, the drugs in yellow, what do? They decrease osteoclast activity. They decreased osteoclast activity. Drugs in blue, what do? They increase osteoblast activity. They increase osteoblast activity. And drugs in orange color, you see, they do both. Fine. The different drugs here, the different drugs which we use: alendronate, risodronate, we use once a week. Ibandronate, we use once a month. Zoledronic acid, once a year. Right. Now the next thing, estrogen. It is used as hormone replacement therapy. Selective estrogen receptor modulator like tamoxifen. Remember, tamoxifen is inhibitory on breast, whereas it is stimulatory to bone and endometrium. That is why it is called as selective. Then we use calcitonin. So calcitonin, it has got, it is considered anti-hormone. It is considered anti-hormone of PTH. Fine. Anti-hormone of PTH. Then denosumab. So this is monoclonal antibody. Monoclonal antibody against osteoclast. Fine. Then we use teriparatide. So basically, what is teriparatide? Teriparatide is synthetic SPTH, synthetic parathyroid hormone, synthetic parathyroid hormone. Now at low doses, it increases bone formation. It increases bone formation. At high doses, it decreases bone formation. So we will give it at low doses. Now strontium ranulate. This is a dual action drug. Dual action drug. But what is the problem? Problem is that it is highly nephrotoxic. It is highly nephrotoxic. Now in osteoporosis, pathological fractures are common. Pathological fractures are common and they commonly occur at wrist joint, that is Colles fracture. They commonly occur at neck of femur, but most commonly they occur at dorsolumbar spine. Most commonly they occur at dorsolumbar spine. आप अब तक orthopedics 2 3 4 बार पढ़ चुके. Fine. Now this area, dorsolumbar spine, that happens to be very, very risky area. Dorsolumbar spine, it is the most common site for tuberculosis. It is the most common site for tumors. It is the most common site for fractures. It is the most common site for fractures. You see, the anterior aspect, it is common site for fracture. Posterior aspect, it is common site for tumors. And entire dorsolumbar spine itself is very, very prone to fracture. Very, very prone to fracture. Fine. Then surgical treatment is vertebroplasty using bone cement. What is the formula of bone cement? PMMA. Polymethyl methacrylate acetate. Polymethyl methacrylate acetate. PMMA. That is the formula. Okay. Now see here. Those of you who have already read, प्लीज आंसर दिस क्वेश्चन. जिन्होंने हो सकता है कि कईयों ने क्वेश्चन भी देखा हो ये वाला, पर चलो कोई बात नहीं, आंसर कीजिए प्लीज. मैं नाम लेता हूं. डॉक्टर जोवित जेम्स जी, डॉक्टर ऋतिक जी, डॉक्टर नाइट, डॉक्टर एंकी. क्या बात, बड़ा खतरनाक नाम भाई. प्लीज ट्राई टू आंसर दिस क्वेश्चन फॉर मी. वेरी इजी क्वेश्चन. I'll wait for 20-30 seconds, then I'll proceed to answer myself. Now I've even called the names. There is some lag, so I'll wait for 20-30 seconds and then I'll proceed. So 68-year-old woman with metastatic breast cancer has been receiving monthly intravenous zoledronic acid. That means a type of bisphosphonate infusion for the past 3 years. Long time. Okay. Now, she now presents with pain, swelling, and an area of exposed bone in her mandible that has not healed for 8 weeks following a tooth extraction. There is no history of radiation therapy to the head and neck. Which of the following is the most likely diagnosis? Now, you see, two things are known complication. First is atypical fractures. Fine. And then radio means visible on X-ray. Osteonecrosis of the jaw bone. Osteonecrosis of the jaw bone. Fine. So we'll go in for this medication related osteonecrosis of the jaw bone. So you see, this is related to bisphosphonate. Now these two are complications. These two are complications of bisphosphonate therapy. Complication of bisphosphonate therapy. Prominent complication of bisphosphonate therapy. Right? See here. Osteonecrosis. See here. At this point, you see the bone is damaged. At this point, you see the bone is damaged. Right? At this point also, you see the bone is damaged. Bone is gone. Osteonecrosis associated with bisphosphonate. And these are atypical fracture. These are atypical fractures. right? Atypical fractures. Okay, right. Acha, another thing you see, rickets you people study in pediatrics also, but even then let's give it a quick round. Let's give it a quick round. We'll study this very quickly. Rickets, right? Now you see, rickets, most common cause in India, that happens to be nutritional deficiency. That happens to be nutritional deficiency. Whereas lack of sun expo. Oh God, okay, lack of sun exposure happens to be the most common cause in European countries. वहाँ के बच्चे खाते पीते बहुत अच्छे, fine, but they don't go out in sun. They don't go out in sun, fine. Now our skin can make its own vitamin D, cholecalciferol by UVB rays. From diet we get ergocalciferol, fine. Now these are inactive. Both of them are inactive. Both of them are inactive. They further go to liver, and liver will convert them into calcidiol. What is the problem with calcidiol? Calcidiol is also inactive, useless, right? Then it goes to the kidney. Now kidney will convert it into calcitriol. Calcitriol is metabolically active, is metabolically active form of vitamin D, right? Now we'll see the cranial, the clinical features. Now craniotabes. Craniotabe is soft skull. Where? Not everywhere, but at the sutures. Now what is important about this? This is the earliest clinical feature. Earliest clinical feature: softening of the skull at suture lines. Softening of the skull at suture lines. Frontal bossing. The brain is growing rapidly, so it is pushing the skull. So you see, the skull is distorted. Skull is distorted. Deformed skull due to growing bone. What is important? Important is the image, right? Then you see Harrison sulcus. Sorry, let's use a better pen. Harrison sulcus is between chest and abdomen. Is between chest and abdomen. See here, Harrison sulcus. Harrison sulcus, also called as Harrison groove. Harrison sulcus, also called as Harrison groove. That is between chest and abdomen. Chest and abdomen, right? Then you see rosary. So there are multiple swellings. Multiple swellings. ऐसे लगता है जैसे मनकों की माला हो कोई. Multiple swellings. Multiple bead-like swellings. Now, this is called as rosary, right? Now, there are two type of rosary which we study in orthopedics. Rachitic rosary. Rachitic rosary, it is seen in rickets, and scorbutic rosary, it is seen in scurvy. Rachitic rosary is painless. Scorbutic rosary is painful, right? Rachitic rosary is round, fine, whereas this is angular. So you see, the swelling will be like this. Here the swelling would be like this, angular, pointed, right? Angular and pointed. That's the difference between rachitic rosary and scorbutic rosary, right? Then you see, we get to see the different deformities. Now the first thing here, what we get to see, that is called as genu varum, genu valgum deformity. I'm sorry, genu valgum deformity. You see, so the word genu means it has got something to do with the knee. And beyond knee के आगे आगे देखो, घुटनों के आगे आगे देखो, limbs, they are going outward. And when the limbs are going outward, name of deformity is genu valgum. Genu valgum, right? Now you see here. So let's have a look at the knee. beyond the knee. You see, limbs are going inwards. Limbs are going inwards. So your patient has genu varum deformity, and very often genu varum is associated with another deformity. Genu varum is often associated with another deformity. What is that? Coxa valgum. Coxa valgum. You see here what is happening, that limbs are going outward. So this is a rule that generally coxa valgum, coxa means hip joint, is usually associated with genu varum, is usually associated with genu varum. Now see the first image again. See the first image again. See, here they are going inwards. You see what joint is there? Hip joint. So we can easily say that our patient has coxa varum plus genu valgum. So coxa varum is generally associated with genu valgum. Generally associated with genu valgum. Genu valgum. Right? Now look at the third image. Look at the third image. Here and here. Now see, here what kind of deformity is there? Varum. On the other side, what kind of deformity is there? Valgum. So genu varum is associated with genu valgum. Now this kind of deformity is called wind sweep deformity. Wind sweep deformity. Varum in one limb and valgus is other. Valgus in the other. So most common cause of wind sweep deformity, that happens to be rickets. Most common cause of this deformity in adults, that happens to be rheumatoid arthritis. That happens to be rheumatoid arthritis. Now, what are the different biochemical values? Different biochemical values. When we talk about the serum calcium values, they are normal or slightly low. They are normal or slightly low. You need to remember one thing, that 99% of body calcium, it lies in skeletal system, and only 1% is in the blood, and that is what we measure. That is what we measure. 1% है केवल ब्लड में, उसको जरा सा चोट लगेगी सब नॉर्मल हो जाएगा. चोट कौन मारेगा? पीटीएच. So normalization of calcium level is done by parathyroid hormone. Parathyroid hormone. Phosphate level and vitamin D levels are low because there is no compensatory mechanism. Alkaline phosphatase levels are very high, because you see our patient is a growing child, so he has got too many osteoblasts in his body. हमारे पेशेंट की बॉडी में कौन से सेल बहुत ज्यादा हैं? Too many osteoblasts. Too many osteoblasts are present in his body. That is why alkaline phosphatase levels are very high. Alkaline phosphatase levels are very high. Right? Now what do we get to see on X-ray? First we get to see cupping. Cupping is deepening. See here. Deepening of metaphysis. Splaying. This is A. Splaying. Splaying means widening of metaphysis. Widening of metaphysis. Fraying. Fraying means rough edges. Fraying means rough edges. आप देखिए डॉक्टर साहब जी, this is absolutely smooth, whereas this is rough. See, rough. These rough margins, that is called as fraying. Fraying. Okay. Now, treatment, of course, you have to give high dose vitamin D, 6 lakh international units, either as intramuscular injection or 6 oral doses of 1 lakh international 1 lakh international units. Phosphate levels begin rising within 4 days, 96 hours. Radiological healing is visible in 6 to 7 weeks in 100% of patient. 100% of patient. Fine. Deformity corrections is done with braces. With braces. Braces means no surgery, non surgical treatment. So this is done when alkaline phosphatase. This is done when alkaline phosphatase levels are normal. Fine. Surgery only done when there is skeletal maturity. When there is skeletal maturity. What are the other features which they might ask you? Pectus carinatum, that is pigeon chest. So you see normally the chest, let's say, is like this. This is posterior, this is anterior. Pectus carinatum is like this. This is posterior, this is anterior. Posterior, anterior. When pectus carinatum. Double malleolized sign, you see here. Double malleolized sign. Bones are very, very soft and they bend. Dental hypoplasia, smaller teeth. Smaller teeth. Okay. Now, then we see osteomalacia. Osteomalacia. So, osteomalacia is commonly seen in females of developing countries. Female of developing countries. So, the clinical features: polyarthralgia, polymyalgia. Fine. X-ray will show something which are called as pseudo fractures, which are also called as milkman fracture. Also called as milkman fracture. इसका दूध वाले से कुछ लेना देना नहीं है. Fine. Actually, it was discovered by one doctor whose family name was Dr. Milkman. Whose family name was Dr. Milkman. Fine. Now, how to differentiate between two type of fracture? Insufficiency fracture, also known as pseudo fractures, also known as milkman fractures. So they occur because of normal load on weak bone. Stress fracture, abnormal load on normal bone. That is how you differentiate between the two type of fracture. For example, मिलिट्री रिक्रूट, नया नया बंदा जो पुलिस में फौज में भर्ती हुआ, रोज परेड करा रहे हैं उससे. ही हैज गॉट स्ट्रॉन्ग बोन्स, हड्डियां उसकी बहुत मजबूत हैं, बट रोज आप बेचारे से परेड करा रहे हो तो हड्डियां बेचारी उसकी कब तक बर्दाश्त करेंगी? एक ना एक दिन किसी जगह से टूट जाएंगी. दैट विल बी कॉल्ड एज स्ट्रेस फ्रैक्चर. एबनॉर्मल लोड ऑन अ नॉर्मल बोन. Now we continue reading about pseudo fracture. Most common site is lower limb, and lower limb, what is the common site? Neck of femur. Neck of femur. These are the other sites. These are the other sites. Right? Now, definitive diagnosis is by trans-iliac bone biopsy. Trans-iliac bone biopsy, which will show reduced bone density, right? Now, what do you get to see here? That appears like a triangle. So this one is typically called as tri-radiate pelvis. Tri-radiate pelvis. Tri-radiate pelvis. Wait. Okay. Now, these days, they have started asking you some difficult question. They have started asking you some difficult questions. So there are some drugs which are associated with the, wait, I want to open it again. There are some drugs which are associated with development of osteomalacia. Fine. For example, anticonvulsant drugs like phenytoin. Fine. Anticonvulsant drugs like phenytoin, phenobarbital, carbamazepine. They are commonly associated with development of osteomalacia. Ifosfamide, cholestyramine. They are associated with development of osteomalacia. ATT, rifampicin, commonly associated with development of osteomalacia. Cadmium, steroids, glucocorticoids. Okay, so they are commonly associated with osteomalacia. Treatment remains the same: vitamin D and calcium. Okay, now let's quickly see some of the important instruments. Two things, right? Now, see here, splints and instruments. Wait. Let's continue reading this only. Yeah, this. Let's continue reading the metabolic disorder. So, osteogenesis imperfecta. Fine. Wait. So, you see, osteogenesis imperfecta, it is known as brittle bone disease. Brittle means something which breaks very, very easily. So it is commonly seen due to defect in collagen type 1, which is seen in the skin, which becomes very, very thin, ligaments which become weak, teeth which become small, and bone which becomes weak. Okay. What is the defective gene? Call 1A1, call 1A2. Fine. What are the clinical feature? Lax ligament, loose ligaments, blue sclera. Sometimes we call it gray sclera, and multiple fractures. Treatment: bisphosphonate or surgical treatment, Sofield Miller osteotomy. It appears like Sikh kebab. So this is also called as Sikh kebab osteotomy. Right? Now, these patients, they are susceptible to malignant hyperthermia. These patients, they are susceptible to malignant hyperthermia. Malignant hyperthermia. You have studied about malignant hyperthermia in what they call pharmacology classes, right? Then osteopetrosis, which is also called as marble bone disease, also called as Aber-Skonberg disease. Aber-Skonberg disease. What is the defect? Defect is carbonic anhydrase pump on the osteoclast. That means osteoclast, they do not function properly. So that is why there is no bone resorption. The old bone is not destroyed. Old bone is not destroyed. Now, it is of two types. In adults, the disease is autosomal dominant, whereas in children it is autosomal recessive, and there is poor prognosis. So children, they often develop hepatosplenomegaly. There is no space for bone marrow. Everywhere there is bone. Everywhere there is bone. So the child generally dies because of infection. Most common cause of death, they are multiple infection. Most common cause of death, multiple infections, right? Now, what do we get to see over here? So this is called as endo bone appearance. Endo bone appearance. What is that? Bone within bone. Bone within bone. See, increased density, normal. Increased. Inside it is still normal. Inside it is still normal. Fine. Bone within bone. Bone within bone. And you see the bone is enlarging rapidly. So this is called as Erlen Mayer flask. Erlen Mayer flask deformity. Erlen Mayer flask deformity. Right? Now the treatment here is stem cell transplant. Stem cell transplant. That happens to be the only available treatment. That happens to be the only available treatment. Right. We now move to the next thing, that is Paget disease, which is also called as osteitis deformans. Osteitis deformans. Right. Now, osteitis deformans, Paget disease, first of all, it is a disease of elderly and it is associated with paramyxovirus. Paramyxovirus. What is the mutation? SQSTM1. SQSTM1 mutation. SQSTM1 mutation. Fine. The common sites are femur, pelvis, and tibia. Femur, pelvis, and tibia. Right. Now, disease is of it runs in three phases. First, lytic phase, there is increased osteoclast function. Then blastic phase, increase osteoblast function. Then sclerotic phase. So there, that's also called as late inactive. Here osteoclast activity declines, but osteoblast activity is still high. Osteoclast activity is still high. Fine. Male female ratio is nearly equal. Male female ratio is nearly equal, and the common age affected is around 50 years. Common age affected is around 50 years. So what happens? Initially, too much bone will be destroyed. Later, too much bone will be formed, and in the third stage, large amount of bone continues to be formed. Here you see, let's quickly revise it. In lytic phase, osteoclast activity is high, osteoblast activity is normal. Fine. Here, osteoclast activity is increased, osteoblast activity is also increased. In the third phase, osteoclast activity is nearly normal, whereas osteoblast activity is slightly high, not too much high, slightly high. Clinical feature: majority of the patients are asymptomatic. Some other experienced clinical feature, most common is bone pain. Fine. Headache, hearing loss. You see, there will be sensorineural hearing loss. Vascular steal syndrome. What is vascular steal syndrome? Blood which is reserved for brain is diverted to skull skull bones. Right. Now here, what do we get to see? Atypical banana fractures. Atypical banana fractures. Fine. That's what we get to see. Banana fractures. What kind of fracture are they? They are transverse fractures. Transverse fracture. Banana fractures. The transverse fractures. Right. Now here we get to see blade of grass. Blade of grass appearance. Blade of grass appearance. This blade of grass, or this is also called as candle flame sign. Candle flame sign. These all are seen in the lytic phase. Fine. In the next phase, plastic phase, we get to see cotton wool skull. We get to see cotton wool skull. Right. Now, what do we get to see? This typical appearance, this is called as picture frame vertebra. Picture frame vertebra. Picture frame vertebra. Now, in the later stages, what do we get to see? We get to see ivory vertebra. We get to see ivory vertebra. This is microscopic picture. Microscopic picture. What is that? Mosaic bone. Microscopic picture, that is mosaic bone. Mosaic means jigsaw puzzle, jumbled up, सब बिखरा हुआ जैसे. Fine. Now, so what is the treatment? Treatment, initially what we do is bisphosphonate. Bisphosphonate. Another thing we can use is calcitonin. And third, surgical treatment, osteotomy. Third, surgical treatment, that is osteotomy. Remember here, teriparatide. Teriparatide is contraindicated because it increases the risk of osteosarcoma. It increases the risk of osteosarcoma. Osteosarcoma. Right? Okay. Now, wait. Yes. So can any one of you tell me what is this sign? Increasing skull size. Why have I used this picture? Any one of you, please. So you see the skull size keeps on increasing. Skull size keep on increasing, right? So your patient starts using this kind of cap. Fine. So this kind of cap, it is called as TAM O center sign. TAM O center. TAM O center, it is a type of cap. It is a type of cap. TAM O center, it is a type of cap. So your patient will have TAM O center sign. TAM O center sign. Okay. Now, achondroplasia is the next thing that happens to be most common cause of genetic dwarfism. Most common cause of genetic dwarfism. There is defect in enchondral bone formation. That is why the clavicle and skull, they are normal. Remember, dear doctor, they have asked you this question n number of times. Clavicle, is the only long bone. Clavicle is the only long bone which forms by membranous ossification, which forms by membranous ossification. Inheritance pattern is autosomal dominant. 80% are spontaneous mutation. There is no family history. What is the gene responsible? FGFR3. FGFR3 is the gene responsible for achondroplasia. Clinical feature: there will be decreased height, there will be decreased arm span, decreased height, decreased arm span, right? Now, what is prominent? Prominent is rhizomelic micromilia. Milia means something related to limbs. Micro means small. Rhizomelic means smaller. Proximally. Smaller. Proximally. What am I trying to say? You see, humerus will be small. Radius will be small, ulna will be small, but humerus will be very, very small. Humerus will be very, very small. Similarly, femur will be small, tibia will be small, right? Fibula will be small, but femur will be very, very small. So shortening, which is prominent in the proximal bone, that is called as rhizomelic. Rhizomelic. Then what we get to see is something which are called as starfish hands. All digits are of equal size. All digits, they are of equal size. Fine. Now see, 1, 2, and 3. Now there is a wide gap. There is a wide gap between middle finger and ring finger. Wide gap between middle finger and ring finger. This particular sign, this is called as trident hand. Trident hand. Trident hand. Very wide gap between middle finger and ring finger. Then you see there will be single crease. There will be single crease on the hand. Single crease on the hand. Now, then the typical pelvis. Champagne glass pelvis. Champagne. Let me write it someplace else. Champagne glass pelvis. Champagne glass pelvis. Okay. Now, vertebrae, bullet shaped vertebrae. Bullet shaped vertebrae. Right. So that was achondroplasia for you. Without wasting any time, let's have a quick look at different kind of fracture. Different kind of fracture. Now, fracture around the knee joint. B for big fracture. Big fracture. B for bumper fracture. Bumper fracture. So you see here, this one is bumper fracture. Bumper fracture. Whenever you see a big fracture, you know that it is a bumper fracture. It is a bumper fracture whenever you see a big fracture. Fine. And whenever you see a small fracture, see here, whenever you see a small fracture, chota sa fracture, whenever you see a small fracture, right, that happens to be C-gond fracture. That happens to be C-gond fracture. C-gond fracture. Now, C-gond fracture, it is generally associated with ACL injury, anterior cruciate ligament injury, anterior cruciate ligament injury, right? Okay. Now, you see here. So, 1, 2, 3, 4, 5, 6. So, whenever you see the C6 fracture, that happens to be, name the fracture please, that happens to be clay shoveler fracture. That happens to be clay shoveler fracture. Clay shoveler fracture. You see there is a fracture over here. Clay shoveler fracture. Right? Now, if your patient, is unfortunately dead, so what is the name of the fracture in dead patient? So in dead patient, the same fracture would be called as undertaker fracture. And it has got nothing to do with the wrestler undertaker. Undertaker are those people which will take the dead body inside the grave. कबर के अंदर जो डेड बॉडी लेके जाएंगे, those people they are called as undertaker. Those people they are called as undertakers, right? Okay. Now, if you see over here closely, there is a fracture over here. C1, C2. So if you see there is C2 fracture, if you notice that there is C2 fracture. So C2 fracture, that is called as hangman fracture. That is called as hangman fracture. Hangman fracture. Now here. So what do we get to see? We get to see an X-ray view called as open mouth odontoid view. Open mouth odontoid view, which is seen in C1 fracture. Which is seen in C1 fracture. C1 fracture. Let me put it like this. Okay. Keep it like this. C1 fracture. Very good. Okay. Now see. This is C2 and this is broken C1. So you see it has gone like this. What is the name of this fracture? That happens to be Jefferson fracture. Jefferson fracture. Jefferson fracture. Right? Okay. Here. So you see, if let's say the lateral malleolus and medial malleolus both are fractured, that happens to be bimalleolar fracture. Bimalleolar fracture is also called as pot fracture, is also called as pot fracture. If the posterior malleolus is also fractured, if the posterior malleolus is also fractured, so that becomes trimalleolar fracture. Trimalleolar fracture, that will be called as cotton fracture. That will be called as cotton fracture. Pot bimalleolar and cotton trimalleolar fracture. Cotton trimalleolar fracture. Right? Okay. Now here. So these are tarsal bone. These are tarsal bone. And these are metatarsal bone. Now if there is a fracture over here, this happens to be Lisfranc fracture. Lisfranc fracture. Lisfranc fracture. Lisfranc fracture. Okay, because you see here this red line. This red line is tarso-metatarsal joint. Tarso-metatarsal joint. See. On this side, what do we have? On this side, we have got metatarsal. On this side, we have got tarsal bone. We have got tarsal bone. Fine. Now, if there is a fracture over here, you see at this point, this is called Lisfranc fracture. Let me erase it. See, Lisfranc fracture. You can see that slippage has occurred. Slippage has occurred. Right? Now, the next one you see. See, dear doctors, what are these? These are metatarsal. What are these? Tarsals. Tarsal bone. Now, this joint, which is called as Lisfranc joint, is normal. So that means what fracture is this? This is a chop-part fracture. What is chop-part fracture? Chop-part fracture is transtarsal. Tarsal fracture. Transtarsal fracture. Transtarsal fracture. You see here. Transtarsal. Tarsal bone. Tarsal bone. Now here. So chop-part fracture. Chop-part fracture. Right? Now here. The aviator fracture. Aviator fracture. Right? Now this one. Watch closely. Anterior part of the spine fractured. Posterior part of the spine fractured. Middle part of the spine fractured. So three fracture, anterior, posterior, middle, all are fractured. So this one is called as jack knife fracture, also called as chance fracture. Thank you. Also called as chance fracture, right? Thank you. Can I get one more, please? Why? Let's just keep it over here. All right. Now, see. So often there is a confusion whether what kind of a fracture is this. Fine. You see the different fracture. You can see one fracture over here, one fracture over here, and one fracture over here. Whether it is, Jones fracture, pseudo Jones fracture, or whether it is just a stress fracture. Okay, so what we do is we'll divide this metatarsal into three zones. We'll divide this metatarsal into three zones. So zone 1, zone 2 and zone 3. The fracture which occurs in the zone 2, that happens to be true Jones fracture. Now, fracture which occurs in the zone 1, that happens to be pseudo Jones fracture, pseudo Jones fracture, right? Now here, dear doctors, can you still, I mean, is there any kind of confusion still? This happens to be pseudo Jones fracture, pseudo Jones fracture. And this fracture, because it is happening in the zone 2, this is the real Jones fracture, real Jones fracture, okay, real Jones fracture. And here, because you see only one side is broken, other is absolutely normal, fine. So we can still say that this is stress fracture, stress fracture. Had it been normal fracture, bone would have broken completely, bone would have broken completely. So just one side there is a small crack, that is why this is a stress fracture, that is why this is a stress fracture. So you see, if the fracture is over here, that is pseudo Jones. If the fracture is over here, that is Jones. And if the fracture is incomplete, that happens to be a stress fracture, that happens to be stress fracture. So remember this image: pseudo Jones, Jones and stress fracture, right? Okay, let's move forward. So this happens to be, I mean, this is called as skyline view, sunset view, sunrise view. Incidentally, all of them are same. All of them are same. What is they use? They are used for patellofemoral dislocation. Used for patellofemoral dislocation, right? Now, this kind of X-ray sign they usually ask in the examination. Remember, they ask you this one-liner question. When I started teaching, they used to ask very, very simple questions. They'll ask you, what is the most common fracture around elbow? What is the most common fracture around elbow in children? That happens to be supracondylar fracture of humerus. Supracondylar fracture of humerus, right? Now, most of the time the fracture is visible on X-ray, but sometimes fracture itself may not be visible, but other signs may be visible. What other signs? So you see here, let's say this bone is fractured. So around the fracture, what will be present? Edema. Now, posteriorly, you see this is the outline of edema. This is the outline of edema. I'll erase it so that you can see again. Anteriorly, this is the outline of edema. So this is called as Sale sign. This is called as fat pad sign. Let me erase it. See. So fat pad sign, like this here. You'll notice that this area appears dark, fat pad sign. And in the front, this triangular area also appears dark. This is called as Sale sign. Let me erase it again. Right? See, this is the sail. This triangular area is called sail here. So posteriorly we get to see fat pad sign, and anteriorly we get to see sail sign. Right? Okay. What is the classification? Classification system is Gartland classification. Now, just out of curiosity, I wanted to study something else. So rather than appearing for the MCH examination, I appeared for NEET PG examination to see what kind of question, what kind of stress is felt by the student. Now, in NEET PG 2024, they ask you this question about Gartland classification. Gartland classifications. You see, type 1, it is incomplete fracture. Type 2, it is complete fracture but not displaced. Type 3 is completely displaced fracture. At least remember the name, Gartland classification. Now, the next classification is now completely important. Salter-Harris classification. You see, the structure of a growing bone. Structure of a growing bone, you know extremely well how it is. See, epiphysis, physis, that means the growth plate. Metaphysis and diaphysis. Diaphysis means the shaft. Now, you see here. So Salter-Harris classification, it is the classification of physeal fracture, the physeal growth plate fracture. Okay, now see, here what happens is that the metaphysis is completely separated from physis. Then type 2, there is fracture above physis, fracture above physis. Type 3, there is fracture below physis. There is fracture below physis. Type 4, fracture both above and below physis. Both above and below physis. Type 5, the physis is crushed. Type 5, the physis is completely crushed. Fine. Salter-Harris classification, very very important, very important. Salter-Harris classification, right? So that was some of the named fractures. Let's quickly study about different type of arthritis, right? We'll study only the important type of arthritis here, four important type of arthritis, and we will quickly start with rheumatoid arthritis. We'll quickly start with rheumatoid arthritis, right? Now, so it is associated with the HSV virus, Epstein Barr virus, Epstein-Barr virus. Fine. It is also associated with smoking. Also associated with smoking. Fine. Now, what kind of HLA? HLA DR1 and DRW4. DRW4. Right. Now, what cytokines are responsible? What cytokines are commonly responsible? Tumor necrosis factor alpha, interleukin 6 and interleukin 1. Fine. What are the most common joints affected? Most common joint affected: metacarpophalangeal joint, PIP joint, proximal interphalangeal joint, wrist joint, metatarsophalangeal joint. Now, what is important over here, that distal interphalangeal joint is spared. Distal interphalangeal joint is spared. Cervical spine, that is C1 C2 joint. Your patient presents with clinical feature. What is the prominent clinical feature? Occipital headache. occipital headache happens to be the prominent clinical feature. Prominent clinical feature. Typical feature is symmetrical polyarthritis. If I'm your patient, right side wrist involved, left will also be involved. Right side fingers involved, left will also be involved. So symmetrical polyarthritis. Now, then your patient will have deformities in the later stages. For example, what do you get to see over here? Mallet finger. See, mallet finger. So there is flexion at the DIP joint, right? And then you see there is flexion at the DIP joint, and then there is extension, let's say hyperextension at the PIP joint, hyperextension at the PIP joint. Fine. What kind of deformity is this? So this kind of deformity is swan neck deformity. Swan neck deformity. Exactly opposite to this. Exactly opposite to this. Flexion at PIP and hyperextension at DIP. That happens to be Bottonier's deformity. Botonier deformity. Yeah, you see, Botonier, swan neck deformity, and mallet finger. Right now, this one is Z deformity. This one is Z deformity. That is hyperextension. Hyperextension. This one is piano key deformity. Piano key deformity. Piano key deformity. Piano key deformity. What is piano key deformity? That is subluxation of radioulnar joint. Subluxation of the radioulnar joint. Investigation. RA factor is raised, but unfortunately, this is non-specific. What is the specific? Anti-CCP antibodies. What is CCP? Cyclic citrullinated peptide antibody. Citrullinated peptide antibody. Fine. Treatment: NSAIDs and DMARDs. Drug of choice: methotrexate. What are the syndromes associated? Felty syndrome, Sjogren syndrome, Felty syndrome, Sjogren syndrome. These are the syndrome which are commonly associated. What exactly is RA factor? That is IgM antibody against FC portion of IgG, against FC portion of IgG. Now, you see, these are the mnemonic for remembering the different drugs, DMARDs. So first mnemonic is ELISA, right? Etanercept, leflunomide, infliximab, sulfasalazine, and Carina. Okay. Please give her methotrexate, penicillamine, glucocorticoid, gold salts, fine. And then another mnemonic is, wait, see, MDSAT. That happens to be another mnemonic. Syndrome associated, Felty syndrome, Sjogren syndrome, and carpal tunnel syndrome. Carpal tunnel syndrome, that is also associated with rheumatoid arthritis. Carpal tunnel syndrome also associated with rheumatoid arthritis. Right? Okay. Yeah. Let's continue reading the different type of arthritis. The next thing which we are going to read is osteoarthritis. Osteoarthritis. So osteoarthritis, most common joint affected is hip joint. In India, most common joint affected is knee joint because of Indian style of toilets and because of our habit of sitting on the ground. हमें आदत है चौंकड़ी मार के पालथी मार के बैठने की. उस सिचुएशन में knee joint is badly damaged, right? What are the joint which are spared? Joint which are spared is metacarpophalangeal joint. Metacarpophalangeal joint. Incidentally, metacarpophalangeal joint is the most common joint affected in rheumatoid arthritis. Now, it's of two types. Primary osteoarthritis, cartilage is destroyed by aging. Secondary osteoarthritis, cartilage is destroyed by infection. Cartilage is destroyed by rheumatoid arthritis. Cartilage is destroyed by fracture. Now, this can affect any joint. Secondary osteoarthritis can affect any joint. Clinical feature: pain. Pain which is worse by evening. Pain which is worse by evening, that means it increases with activity. It increases with activity. Swelling, decrease walking distance, and genuvarum are other clinical features. Right? Now here, so you see 1 and 2. 1 and 2. So 1, that is swollen PIP joint. Swollen PIP joint, what is that? Bouchard. No. Then 2. Swollen DIP joint, what is that? Heberden node. Heberden node. Heberden node. Right? What is this deformity? That happens to be genuvarum. Genuvarum is common in osteoarthritis. Say it is like this. Osteoarthritis. Fine. Okay. X-ray finding. Typical X-ray finding. You see, there is no space. Whereas on the other side, some space is still present. So the finding, X-ray finding is asymmetrical loss of joint space, and where it is more on the medial side than lateral side. More on the medial side than lateral side. More on the medial side than lateral side. Right? You see here. Medial side there is absolutely no space, whereas on the other side some space is still present. Some space is still present. Right? Then you see rough edges. So these rough edges, they are called as osteophytes. They are called as osteophytes. Osteophytes. See, these rough edges, they are called as osteophytes. Osteophytes. So gold standard investigation, that means confirmatory investigation, that happens to be arthroscopy. Artho means inside the joint. Scopy means we will take a camera and go inside the joint. And what do we get to see? We get to see loose bodies. What are loose bodies? Loose bodies are damaged cartilage, parts of the damaged cartilage. Most common cause of loose body in the joint that happens to be osteochondritis dissecans, osteochondritis dissecans, whereas most common cause of loose bodies in the elderly that happens to be osteoarthritis, right? Okay, treatment is not important here, right? So we move to the next thing there, and that happens to be psoriatic arthritis. Now it is called as arthritis mutilans. Why? Because it badly destroys the joint. It badly destroys the joint. It is called as seronegative arthritis because what we notice is that the R factor is almost always negative. It develops in the people suffering from psoriasis. Develop in the people suffering from psoriasis. Male female ratio is equal. What is the age group? 30 to 50 years. It is common in the people who are 30 to 50 years of age. Fine. What is the HLA associated? HLA associated is HLA B27, and this point is very, very important. HLA B27. Clinical feature, most common pattern, asymmetrical. So on left side wrist joint may be involved, whereas on the right side fingers may be involved, right? Fingers may be involved. Then what do we get to see? Telescoping. Telescoping of the digits. Oh no, sorry. So we get to see sausage shaped fingers. Sausage shaped fingers are seen. Osteolysis, it causes telescoping of the digit. Telescoping, you pull this finger and the finger would become longer. You release this finger and finger will become smaller. Finger will become smaller. Osteolysis means bone destruction. And then you see there are skin folds. You see there are skin folds. Now these skin folds, what are they called? These skin folds, they are called as opera glass hands. Opera glass hands. Opera glass hands. The skin folds, they are called as opera glass hands. Fine. Telescoping. So this happens to be a telescope. So different criteria, Moll and Wright criteria, Casper criteria, not important. I mean, important for NEET PG because there are more chances of asking difficult questions here. Now, what do we get to see? Pencil cup deformity, it is seen on X-ray. So you see, dear doctor, this happens to be the cup and this happens to be the pencil. Pencil cup deformity, it is seen on the X-ray. Pencil cup deformity, it is seen on the X-ray, right? And then when the healing occurs, we get to see ivory phalanx. We get to see ivory phalanx. This is seen when the bones finally heal. When the bones finally heal, we get to see ivory phalanx, right? Treatment, all these treatment, NSAIDs, retinoids, immunosuppressants, steroids, and cytokine blockers, direct cytokine blockers, right? Okay, so dear doctors, I want to go in for a quick, short 5 minutes break. Fine. By my watch, let's say it is 7:47. So I'll be back at around 7:52. I mean, after 5 minutes, dot after 5 minutes, we'll be back. Right. I hope it's okay if I can go in for a quick 5 minutes break. After sharp 5 minutes, I'll be back with you and we'll cover the rest of the topics. If any one of you can please send me a message, I can go in for a very short break. I need to put my phones on charging actually. This should go. Right? Thank you so much. We'll go in for a short break. Everything will be on. You'll be continuing with the same link. Everything will be on. Right, dear doctors, I'm back here. Let me see if I'm audible and visible here. Yes, yes, yes. If anyone of you can please let me know if I'm audible and visible, I'll start. So you see, we'll start with the different splints and instruments. That happens to be an Austin Moore pin. That happens to be an Austin Moore pin. Austin Moore pin. Now, this happens to be an Austin Moore prosthesis. Austin Moore. Austin Moore prosthesis. Hip prosthesis. You see, there are two holes. There are two holes. So you see, Austin Moore prosthesis, it is made of single body with two holes. Single body with two holes. Single body means femur head and femur neck. They are present in single body, right? Now, this is Austin Moore pin. If you see this screw in the center, this is Austin Moore. If you see that there is absolutely no screw, but yes, there are some threads. See the threads. That happens to be Denham pin. Denham pin. Now, S for Steinman. S for smooth. If there are no thread, that happens to be Steinman pin. That happens to be Steinman pin, right? And if it is made up of comparatively thinner material, that happens to be a wire. What is that wire? K wire, also called as Kirshner wire. K wire, also called as Kirshner wire, right? Thank you. Now, what are these? These are Crutchfield tongs. Crutchfield tongs. Crutchfield tongs, they are used for skeletal traction. They are used for skeletal traction. Fine. Now here, again, this kind of prosthesis, this is called as Thompson prosthesis. Thompson prosthesis, which is made up of single solid body. Single solid body. Then this one is bipolar hip prosthesis. Bipolar hip prosthesis. So you see here bipolar head and neck, they are of different types and they are held together. And then you see there is another inner lining also, that makes it bipolar. It can move in multiple direction. It can move in multiple directions. That's why it's called as bipolar. Now, this is gallows traction used in children less than 2 years. Fine. You see the hips don't touch the bed. Hips, they don't touch the bed. This one is Bryant traction, also called as Russell traction. Bryant or Russell traction. Fine. Now, this is Hamilton Russell traction. Hamilton Russell traction. How will you identify? It is tied to an overhead source. You see here, it is tied to an overhead source. And if the knee joint is held at 90 degrees, that will be 90-90 traction. 90-90 traction. See, hip joint is held at 90 degrees. 90-90 traction. Okay. Now this is Buck's traction. Buck traction. This one, very commonly asked question. This is Bowler Brown splint. 1, 2, 3 pulleys. Bowler Brown splint. Bowler Brown splint. Fine. This one is Kramer wire splint. Kramer wire splint. This one is ulnar gutter splint. Ulnar gutter splint. Where do we use it? We use it for boxer fracture. Boxer fracture. Right? Now here, you see, this one is frog splint. Frog splint. Frog splint. Why? Because you see the finger is held in flexion. F for flexion, F for frog splint. F for flexion, F for frog splint. Right? Now this one, finger is held straight. When you see the finger is held straight, S for straight, S for stacks splint. Now this one, it is used for mallet finger. It is used for mallet finger. And frog splint, it is used for jersey finger. It is used for jersey finger. Right? Tri-point splint. Tri-point splint, it is used for swan neck deformity. It is used for swan neck deformity. See buddies, if the finger is held in flexion, if the finger is held in flexion, that happens to be a frog splint. If the finger is straight, that happens to be stacks splint. So you see, straight finger, stacks. Bent finger, frog splint. Frog splint. Right? Now see, this one, it is used for ulnar nerve injury. Ulnar nerve injury. This splint, it is used for radial nerve injury. Radial nerve injury. Right? Now, hip spica cast. Hip spica cast, they are used for femur fracture. Femur fracture. Right? This one is buddy strapping. Buddy strapping. Right? Buddy strapping. Now, this one is Milwaukee brace. Milwaukee brace. And this one is Boston brace. Boston brace. You know, Milwaukee, again, it is a city in the US. Boston, again, it is a city in the US. Now, these two are used for scoliosis. These two are used for scoliosis. Fine. Now, here, the third one. Third one, it is called as turnbuckle cast. Turnbuckle cast. Don't confuse it with turnbuckle splint. You see, this is a turnbuckle cast. So, turnbuckle cast, it is used for scoliosis. Turnbuckle splint, it is used for Volkmann ischemic contracture. Name is similar, but uses are different. Turnbuckle cast is for scoliosis, sidewise bending of the spine, and turnbuckle splint, it is used for Volkmann ischemic contracture. Volkmann ischemic contracture. Okay. Now, this one is giggly saw. This is used for cutting the bone. Another instrument which is used for cutting the bone, that happens to be osteotome, for creating a hole in the bone. Osteotome, sharp instrument. Now, this one is periosteum elevator. Periosteum elevator. They appear similar, but what do you notice? That it has got round edges, not the sharp one. Round edges, not the sharp edges, not the sharp edges, right? Now here, this one is bone nibbler. See, bone nibbler, okay? And other one, this one is bone cutter. You cut small bones with it. And if it is a rounded one like this, it's a rounded one. This one is called as rib cutter. Rib cutter. That's the difference between these three instruments. Very good. Very good. Okay. Right. So, very well. Let's quickly see the different tumor. Very well. Let's see the tumors. Right. So, less than 40 years of age, what kind of bone tumors are common? What kind of bone tumors are common? Less than 40 years of age, benign bone tumors are common, and more than 40 years of age, malignant bone tumors are common. Now, most common malignant bone tumor are secondary cancers from other organs. Secondary cancer from other organs. Now, why this logo Canada? Why this logo Canada? This will help you remember. This will help you to remember. I'm from Punjab, and what I notice is that in Canada, that my brother, my brother-in-law, and many of the friends, they live in Canada. Fine. They say every time something bad happens, most of the time local Canadian people are not involved. Most of the time, who are involved? We, Punjabi people. Fine. Something bad happens in Canada, we will be there. Fine. I mean, we will be the cause. So, same way, the own people of Canada, they are not responsible for many problems. We people are the problem there. Right. So, same way, bone, own cells of the bone, they don't turn malignant. Most of the time, the cancer of the bone will come from some other organ, and most commonly it will come from the prostate. So prostate cancer commonly goes to the lumbar vertebrae, Now, then the next one is breast cancer. It commonly goes to the thoracic vertebrae. So secondary bone cancers, they are 50 to 100 times more common than primary bone tumors. Right? Now, most common primary malignant bone tumor, that happens to be multiple myeloma. Multiple myeloma. Now, it arises from red bone marrow. It arises from red bone marrow. Like not from the hard part of the bone, but at least from some part of the bone. Now, most common benign bone tumor, that happens to be osteochondroma. Most common benign true bone tumor, that happens to be osteoid osteoma. Osteochondroma, it stops growing after a while. So that is why it cannot be called as a true bone tumor. It cannot be called as a true bone tumor. Fine. Okay. So it regresses before skeletal maturity. When the bones become mature, this tumor stops growing. Most common site, that happens to be metaphysis around the knee joint. Now, the syndrome associated, Masada syndrome. Treatment is extraperiosteal incision if symptomatic. How symptomatic? It can cause bursitis, it can cause compression of a nerve, compression of a nerve. Okay, and chondroma. It is the most common benign tumor affecting hand bone. Most common site are the phalanges. Most common site are the phalanges. Fine. So that's a typical appearance. Typical appearance. Fine. Now we look at it and we'll see that it appears similar to spina ventosa. What is spina ventosa? Tuberculosis of the hand bones. Tuberculosis of the digits is spina ventosa. So that appears very, very similar. Your patient can have multiple enchondromas. Multiple enchondromas, they are associated with Ollier disease and they are associated with Maffucci syndrome. They are associated with Maffucci syndrome. Fine. Treatment is excision. Treatment is excision. Okay. Then osteoma. Again, it is not an osteoid osteoma. It is just osteoma. What exactly is osteoma? Osteoma is just bone overgrowth. Is just bone overgrowth like this. You see, it is just bone overgrowth. At one point, just that the bone is overgrowing a little, but it is absolutely normal. It is absolutely normal. It does not cause any problem at all. Only thing is that it may cause cosmetic disfigurement. It may appear ugly, nothing else. Fine. You see here. But sometimes, what it may do is, sometimes it may block a paranasal sinus. Sometimes it may block a paranasal sinus. In that case, what it will do, it will cause sinusitis. It will cause sinusitis. Right? So clinical feature, it may cause sinusitis. It may cause a cosmetic deformity. It may cause a cosmetic deformity. Right? So that is why, if it is just a cosmetic deformity, what is the treatment? Treatment is reassurance. If it is causing sinusitis, treatment is excision. Treatment is excision. Now let's say this cell is osteoblast. Let's say this cell is osteoblast. Number of tumors they appear from it. Number of tumors they appear from it. For example, osteoid osteoma, osteoblastoma. Fine. Osteosarcoma. It also appears. It also appears from the osteoblast. It also appears from the osteoblast. You see the different variants. Those of you who have watched this movie, let's say this is the dad, osteoblastoma. So osteoma will appear from osteoblast. Fine. Osteoid osteoma will appear from osteoblast. Osteoblastoma will appear, and the most dangerous of all, osteosarcoma, that will also appear from the osteoblast. That will also appear from the osteoblast. So in this movie, Gangs of Wasseypur, this was the father, and all of these, they were the sons. So all these tumors, they arise from osteoblast. They arise from osteoblast. Fine. Now dangerous level increases. Osteoma least dangerous. Osteosarcoma most dangerous. Okay. Right. So we'll now study osteoid osteoma. We'll now study osteoid osteoma. Fine. So it is the most common true bone tumor. Fine. It is seen in second to third decade of age, and it is common in males. And most importantly, it is seen at diaphysis. It is seen at diaphysis. This is the period of rapid growth. This is the period of rapid growth. Okay. Now this is the typical X-ray picture. This is the typical X-ray picture. So central translucency means something dark in the center, whereas the periphery is white. Periphery is white. See this typical picture. Center is dark and periphery is white. Center is dark and periphery is white. Right now, there is pain relief with NSAID. Pain relief with NSAIDs. Okay, what are the other treatment? Radio frequency ablation or curettage, surgical treatment. Curettage is surgical treatment, right? Then osteoid or osteoma, it is perfectly benign. Osteoblastoma, even this is benign but aggressive. Benign but aggressive. Benign but aggressive tumor. Osteoid osteoma versus osteoblastoma. Right now, you see the difference. Osteoid osteoma versus osteoblastoma. Age is nearly the same. Fine, but difference is size. So this one is small in size. This one is comparatively bigger. This is seen at femur or tibia diaphysis, whereas osteoblastoma it is seen at spine. Neoplastic behavior in both cases it is benign but aggressive. Osteoblastoma is slightly aggressive. Relief with the NSAID, it is good for osteoid osteoma. Fine, why? Because you see this tumor it produces prostaglandins, right? That's why pain relief with aspirin is good. Okay. Now, radiofrequency ablation and curettage is the treatment, whereas marginal excision, that means we will remove tumor plus some healthy tissue. Tumor plus some healthy tissue will be removed. Now, the next one, next tumor that happens to be osteoclastoma. Osteoclastoma. It's also called as giant cell tumor, common between 20 to 40 years of age, and it is common in females. It is common in females. Now, let's say here diaphysis, metaphysis, epiphysis. So you see this tumor will be clearly seen at epiphysis, but not in the center. This tumor will not be seen in the center. This tumor will be seen at the side. So epiphyseal location, eccentric, that means away from center. Expansile means rapid growth. Eggshell crackling means makes the bone very thin. N block excision is the treatment. N block excision is the treatment. Okay, why it is called as giant cell tumor? Because when you do the microscopy you will get to see multiple giant cells. Then UBC, unicameral bone cyst. Commonly it is seen between 4 to 10 years of age. Most common location, metaphysis of the humerus. Okay, then what are the causes? Brodie's abscess, it has got pus. And chondroma, if it becomes liquefied, it becomes unicameral bone cyst, also called as simple bone cyst. So cyst means some liquid is there. Cyst means some liquid is there. Eosinophilic granuloma. Again, you see pus is formed. Hemophilia, swelling will have blood. Again, liquid. X-ray will show trapdoor sign or fallen leaf sign. So you see one bone fragment would be seen suspended. So you see there will be floating. There will be floating bone fragment. Floating bone fragment. Floating bone fragment. That is called as fallen leaf sign. That is called as trapdoor sign. Trapdoor sign. Treatment is intralesional injection of steroid or nitrogen cautery. Nitrogen cautery will make it liquid. Will freeze it basically. Aneurysmal bone cyst. Aneurysmal bone cyst. So this occurs because of USP6 mutation. Now where it is common? It is common at metaphysis. It is common at metaphysis. Now X-ray, it typically shows this finger in the glove appearance. X-ray, it typically shows finger in the glove appearance. Finger in the glove appearance. So this one is the glove. Finger in the glove appearance. Finger in the glove appearance. That's typically seen on the X-ray. Finger in the glove appearance. Right? So there is increased matrix metalloprotease production. So that means what happens? Bone is destroyed. Bone is destroyed. Empty space, it is filled with blood. Empty space, it is filled with blood. Okay. Now, treatment is wide excision allograft. Allograft means you take bone from some other place and fix it over here. That's basically bone implant. Right? Then osteosarcoma. Osteosarcoma, very important bone tumor. That happens to be most common primary bone tumor of non-hematopoietic. That means it does not arise from bone marrow. Does not arise from bone marrow. Fine. So it is the most common malignant bone tumor in children. It is the most common radiation resistant tumor. It is the most common radiation induced bone tumor. Radiation coming from nuclear accident. Radiation coming from nuclear accident. Right? Most common site is metaphysis of femur. Metaphysis of femur. If it is radiation induced, skull is the most common site. Skull is the most common site. Right? Now it is of two types, primary and secondary. Primary means occurs de novo. Occurs de novo means without any other bone disease, without any other bone disease. So this is common between 15 to 20 years of age. Secondary, that means due to some other disease, and it commonly occurs with Paget disease. Paget disease. Right? Now this is common in elderly. This is common in elderly. Okay. Now it is a bone forming tumor. Bone forming tumor. Right? Okay. You see here. Periosteum will be lifted up. Now you people know that periosteum is attached to the bone with the help of fibers. Now, what are these fibers called? These fibers, they are called as Sharpie fibers. So the bone forms over Sharpie fibers. Bone forms over Sharpie fibers, which is typically called as sunburst appearance. Sunburst appearance, also called as sun ray appearance. Right? Now, make sure you don't mark this image wrong. Sunburst appearance and sunburst trabeculation are totally different. Totally different. Now you see central black area. Fine. You see nothing below the periosteum. Make sure you don't make this mistake. It will be seen in skull only. It will be seen in skull only, because you know in an exam they are going to ask you this image only. So this image is not that of osteosarcoma. This image is not that of osteosarcoma. No. Fine. This image is that of hemangioma. This image is that of hemangioma. Right? Okay. Now, another thing which you get to see is like this. So, bone will be completely destroyed. Periosteum will be slightly lifted up. When the periosteum is slightly lifted up, that is called as Codman triangle. That is called as Codman triangle. Codman triangle. Periosteum slightly lifted up. Can you see here? Here the periosteum is slightly lifted. Periosteum is slightly lifted. So this is called as Codman triangle. So Codman triangle is seen in aggressive cancer. It is seen in aggressive cancer. Seen in aggressive cancer. Codman triangle. Now see, because many of you find it difficult. So you see it happens when there is a tumor which is rapidly growing. It will lift up the periosteum, and below the periosteum a triangular area appears. This triangular area is Codman triangle. Is Codman triangle. Right? Codman triangle. Okay. Most common site of metastasis that happens to be lungs. That happens to be lungs. Now what are these? These are the biopsy findings. These are the biopsy findings which are seen. Biopsy findings. These are biopsy findings which are seen in osteosarcoma. Right? Treatment is chemotherapy followed by surgery. Followed by surgery. Radiotherapy is not helpful because the tumor is radio resistant. So these are the protocols of chemotherapy. Protocol, when to give which drug. Now they ask you a very common question. Why chemotherapy is done first? Why chemotherapy is done first? Because most of the tumors they are metastatic. Most of the tumors they are metastatic at the time of presentation. Metastatic at the time of presentation. Most of the tumors they are metastatic at the time of presentation. Okay, so they can be managed only with chemotherapy. Surgery will be done later, right? Okay, Ewing sarcoma that happens to be most common malignant bone tumor of multi-centric origin. Fine. Most common age 5 to 15 years. 5 to 15 years. Most common site that happens to be femur diaphysis and flat bones like pelvis. Clinical feature: pain and swelling. Pain and swelling. There are no draining points. It appears similar to osteomyelitis. It appears as if pus is there, but there are no draining points. There are absolutely no draining points. X-ray will show laminated. Laminated. Laminated means layers. POR. POR is periosteal reaction. Periosteal reaction. You see, there will be multiple layers. There will be multiple layers. Multiple layers. This is called as onion peel appearance. You see here, the layers are more, clearly seen. Multiple layers. So multiple layers are seen. That is lamellated. Lamellated means layers are present. Biopsy, it will show you small round cells with pseudo-roseate. Small round cells sitting in the circle. Sitting in the circle. So this is roseate. This is roseate. Fine. Small round cells sitting in circles. This is all pathology. Treatment is chemotherapy and surgery. The tumor is radiosensitive, but since patients are young children, patients are young children, that is why radiotherapy is avoided and surgery is preferred. That is why surgery is preferred. That is why surgery is preferred. Right? Then multiple myeloma. Multiple myeloma. Most common primary malignant bone tumor. It arises from red bone marrow. It arises from red bone marrow. Most common age 50 to 70 years. Most common site lumbar vertebrae. Fine. Clinical feature: bone pain which increases with activity. Systemic problem: fatigue. Your patient is always tired. Fine. Your patient will have shortness of breath due to anemia. Short duration disease. It kills your patients within 6 months of diagnosis. Within 6 months of diagnosis. X-ray is going to show you rain drop skull. Hello G, Dr. Smooth specialist. Sir. Histopathology, it will show plasma cells with clock face nucleus. Clock face nucleus. Investigation: raised ESR and hypercalcemia. Raised ESR and hypercalcemia. Remember, hypercalcemia, this occurs because of bone destruction. This occurs because of bone destruction. Right? Treatment. The tumor is radiosensitive and we use chemotherapy. So we use a combination of radiotherapy as well as chemotherapy. Now, if at all we have to use the drugs which is commonly used now is thalidomide and bortezomib. Now, melphalan, it is an old school drug. So these days we prefer using thalidomide or bortezomib, which is comparatively newer drug. Comparatively newer drug. Now, most of the time in the classes, the students have been asking me about the difference between rain drop skull and salt and pepper skull. Now, the name itself, salt, is white in color. So there will be sclerotic area. Sclerotic area means the area of dense bone. The area of dense bone. So they will be white in color. And then pepper is black. So you see, there will be area of decreased bone density. There will be areas of decreased bone density. So here, in the salt and pepper skull, you will see some of the areas as bright white. whereas you will see some of the areas as dark black. Some of the areas you will see as dark black. So when you see white and black areas, you know it's salt and pepper skull. And when you see gray and black areas, you know it is raindrop skull. If you see any area as bright white, you will immediately see that it is salt and pepper skull. It is salt and pepper skull. Whereas if you see now, you know, compare both these images. What do you get to see in this images? That some areas of the skull, they are gray white. But what do you get to see in this image? Some areas of the skull, they are bright white. So if you see bright white plus black combo, it is salt and pepper skull. If you see gray white plus black combo, it is raindrop skull. It is raindrop skull. So that is the difference here. That is the difference between salt and pepper skull and raindrop skull. Salt and pepper skull and raindrop skull. Okay. Now we are left with one small topic from the arthritis, and that was ankylosing spondylitis. So ankylosing spondylitis, it is associated with HLA B27, HLA B27 in 90% of the patient. Now axial skeleton, the central part, you know, the earliest site is sacroiliac joint, sacroiliac joint, then lumbar spine, then thoracic spine, then cervical spine. This is how the disease progresses. Okay, primary site of inflammation is anthesis. It is the site of attachment of ligament and tendon with bone. जहां पे ligament और tendon bone के साथ चिपकेंगे, that area is called anthesis. Now this disease is common in males 15 to 25 years of age. That means it is common in young males. It is common in young males, right? So clinical feature: morning stiffness and dull low back ache. Fine. Extra articular manifestation: your patient will have iridocyclitis, that is uveitis. Fine. IgA nephropathy, inflammatory bowel disease, cataract and glaucoma. Cataract and glaucoma. Modified New York criterion, it is used for diagnosis. What is important, dear doctors? Name only. Just remember the name. Don't go in for details. Don't go in for details. Just the name itself is important. You don't have to go in for name for the details. Right, G? Now, limited lumbar spine movement, that is called as Scober test. Scober test. Your patient will not be able to bend properly. Now, what are the tests for sacroiliac joint? That is called as figure of four test. Figure of four test, also called as Faber test. Also called as Faber test. Figure of four test, also called as Faber test. What are radiological signs? So the first radiological sign is haziness and widening around the sacroiliac joint. Haziness and widening around the sacroiliac joint. Now see the different images. First, all the vertebrae, they fuse with each other. That is bamboo spine. Then the second image. So you see bright white line in the middle. That happens to be dagger spine. This is because of calcification of intra spinous and interspinous ligament. Okay, bamboo spine. Now if you see bright white line on the side, so let's say this is image 3 and this one is image 4. You see bright white line on the side, that happens to be railroad sign. And if you see bright white line on the side and also in the center, this happens to be trolley track sign, trolley track sign, trolley track sign, right? So you just see one line in the center, dagger sign. You just see two lines on the sides, railroad sign. You see lines on the side as well as in the center. That happens to be trolley track sign. Treatment is NSAIDs and infliximab. NSAIDs and infliximab, right? Okay. Now see the tuberculosis, most important disease here. Now, whenever you see two vertebra affected, and they have given you an image as a question, two vertebra affected, do consider tuberculosis. Do consider tuberculosis, because all the other diseases where two consecutive vertebrae are affected, they are very, very rare. Very, very rare. दो वर्टेब्रे ऊपर नीचे वाले इकट्ठे कोई बीमारी है उनको हमेशा टीबी सोचो, बाकी सारी बीमारियां बहुत रेयर हैं, बहुत रेयर हैं। आप देखिए बड़े बड़े टीचर से आप पढ़ते हैं, वो सारे वो बीमारियां पढ़ाते ही नहीं है, बिकॉज दे आर नॉट इंपॉर्टेंट बाय एग्जाम पॉइंट ऑफ व्यू। वो गलत नहीं है, बिल्कुल सही है अपनी जगह पे, राइट? बट whenever you see two vertebrae affected, do consider tuberculosis. Two consecutive vertebrae affected, fine, then always consider tuberculosis. Okay, right. Now tuberculosis, also known as king's evil, also known as white plague. Tuberculosis of the spine is also known as pot disease. Tuberculosis of the digits, spina ventosa. Tuberculosis of the shoulder, caries sicca. Tuberculosis of the lungs, remember it is called as Cox disease. Here it is called as Cox disease. Most common type of tuberculosis is pulmonary tuberculosis. Fine. Second most common type is the tuberculosis affecting lymph nodes. Which lymph nodes? Cervical lymph node. Which cervical lymph nodes? Jugulo-digastric. Jugulo-digastric. Third most common type is skeletal, whereas in some books it is written as genitourinary. Most common site is dorsolumbar junction. Dorsolumbar junction, that is T11, T12 and L1. So these three vertebrae are commonly affected. These three vertebrae are commonly affected. Now most commonly it occurs at anterior aspect of the spine, and most common pattern is peridiscal. That means around the intervertebral disc, around the intervertebral disc. The second most common type is central. Now here, this will occur if the bacteria reach by arteries. This will occur if the bacteria reach by veins. And third most common type is anterior. Anterior means anterior to vertebral body. Anterior to vertebral body. Least common type is posterior. Least common type is posterior. Now posterior, if they give you that what structure, spinous process, very less common, and facet joint, extremely uncommon. एक्सट्रीमली अनकॉमन। सिर्फ किताबों में लिखा गया है tuberculosis affecting the facet joint. Spinous process is rare, but facet joint is extremely rare. Extremely rare. Clinical feature: insidious onset back pain, twist tenderness. You ask the patient to twist the body, there will be pain. Coin test: patient does not flex his back while picking object from the floor. पेन नीचे गिराओ, मरीज को बोलो उठा के दे, मरीज अपनी कमर बिल्कुल भी नहीं मोड़ेगा. No flexion at the back is the rule. Right? Earliest neurological sign is clonus. Fine. This occurs due to increased deep tendon reflexes. Increased deep tendon reflexes. Paraplegia is of two types: early paraplegia and late paraplegia. Early is due to pressure of the pus. Good prognosis: remove the pus and there will be recovery. Remove the pus and there will be recovery. Late onset paraplegia, poor prognosis. Fine. So poor prognosis because it occurs due to fracture. Investigation of choice for tuberculosis is MRI. Gold standard investigation: culture of mycobacteria. X-ray: what is the earliest change? Loss of curvature. Loss of curvature of spine. Calcification of paraspinal abscess. Fine. That happens to be most pathognomic sign. That happens to be most pathognomic sign. Now, when the vertebrae are destroyed, one vertebra destroyed, it is called as knuckle. 2 to 3 vertebra destroyed, it is called as gibbous. More than 3 vertebra destroyed, it is called as kyphosis. It is called as kyphosis, the deformities. Treatment: ATT. Surgery if there is deformity or if there is more than 50% sensory loss. 50% sensory loss. Fine. If there is urine or fecal control loss, if the patient cannot hold back urine, if the patient cannot control his feces, fine. So we will say bladder or bowel control is lost. Fine. Now, deformity either by Milwaukee brace or by Taylor brace. Taylor brace, it is used for stabilization. It is used for stabilization of the spine. Used for stabilization of the spine. So that was very important topic, that is tuberculosis. Now we start with another very small topic. Very small topic. Right? Baker cyst. Baker cyst. So they asked in this year exam about the Baker cyst. Baker cyst. Fine. So it is seen at posterior. It was an image based question. It is seen at posterior aspect of the knee joint. Posterior aspect of the knee joint. Now the swelling will become prominent on knee extension. Will become prominent on knee extension. Treatment is excision if it is symptomatic. Then the different kind of bursitis. Different kind of bursitis. Right? Now you see the housemaid knee. Housemaid knee. Fine, like this. Prepatellar bursitis. Then clergyman knee. So this happens to be clergyman. So infrapatellar bursitis, clergyman, housemaid. Student elbow. It is also known as minor elbow. Fine. Also known as minor elbow. So what exactly is this? That this is olecranon bursitis, and all of them are very painful. All of them are very painful because bursae have got too many nerves, nerve ending. Then ischial bursitis is weaver bottom. Ischial bursitis is weaver bottom, right? This guy happens to be a weaver. Ischial bursitis. What is the difference between tennis elbow and golfer elbow? So tennis elbow, it will affect the lateral epicondyle, whereas golfer elbow, it will affect the medial epicondyle, tennis elbow. So tennis elbow, the lateral condyle, and golfer elbow, the medial condyle. What are the tests? You need to remember their name: Cozen test and Maudsley test. Important. Carpal tunnel syndrome, entrapment of median nerve at the wrist joint. It is common if your patient has rheumatoid arthritis, diabetes mellitus, hypothyroidism, or obesity. What are the tests? Fallon test, reverse Fallon test, and Tinel test. Treatment is physiotherapy, or ultimately you will have to go in for surgery, right? So you see, entrapment of median nerve. This is median nerve below the flexor retinaculum. This is flexor retinaculum. So ultimately you'll have to give a cut over here. Fine. Okay. Tarsal tunnel syndrome, it is due to entrapment of tibial nerve, Fine. Haglund deformity, right? So there will be a painful swelling below the calcanea, behind the calcanea. It is associated with plantar fasciitis. Then two types. So trigger finger and Dupuytren contracture. So if you feel a nodule at the metacarpophalangeal joint, near the metacarpophalangeal joint, that happens to be a trigger finger. But if you feel fixed deformity, if it is a fixed flexion deformity, that is Dupuytren contracture. Like this. Fixed flexion deformity. That is Dupuytren contracture. Fine. And if there is a nodule plus click, 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 click sound, that happens to be a trigger fingers. You see here. Dear doctors, this one is metacarpophalangeal joint, right? This one is proximal interphalangeal joint. This one is distal interphalangeal joint. So if there is a nodule near metacarpophalangeal joint, that is a trigger finger. And if it is permanently fixed deformity, fine, patient cannot do any extension. So this is flexion, which is possible, and this is extension of the finger, which is not possible. So we say our patient has Dupuytren contracture. Now decurvane. So you see this area here. This is called as anatomical snuff box. If there is inflammation around the tendons, that is called as de Quervain disease. So inflammation of abductor pollicis longa and extensor pollicis brevis tendon. Investigation: classical and modified Finkelstein test. Fine. Treatment: NSAIDs, physiotherapy, and surgery. Now, ganglion. You see, ganglion most commonly seen on the dorsal aspect of wrist. Now, it is also called as Bible cyst. Complete excision is necessary. Otherwise, you can just do the aspiration. Now, this one, javelin thrower's elbow. Acute injury to ulnar collateral ligament. Acute injury to ulnar collateral ligament. Ulnar collateral ligament around the elbow. Javelin thrower elbow. Javelin thrower elbow. Right? Now, very quickly. Hip joint. Developmental dysplasia of hip. Fine. 2 days back, there was interview of junior resident at my hospital, and I asked this question, that developmental dysplasia of hip is common if the mother has oligohydramnios. Fine. The gynecology doctor who was sitting beside me in the interview panel, very fine lady, she said, don't you think you're asking a very difficult question to this candidate? I said no, because what am I trying to ask is, I'm trying to ask about developmental dysplasia of hip, and that happens to be most common congenital orthopedic disorder around the world. Around the world. In India, what is the most common disorder? In India, the most common disorder is club foot. Most common disorder is club foot. Now, developmental dysplasia of hip. It is seen in FFFF. Remember cholelithiasis? Fat, fertile, flatulent female of 40. That is common in females, cholelithiasis. Similarly, developmental dysplasia of hip. This is also common in females. This is common if there is family history. This is common if there is family history. Right? This is common in the firstborn. This is common in the firstborn. This is common if there is foot first delivery. This is common if there is foot first delivery. What is that? Breech delivery. Breech delivery. Right? Clinical feature: apparent shortening of the limb. No real shortening. They just appear small. They just appear small. Fine. Now, toe walking. The child will be walking on the toes. Waddling gait. Waddling gait if the patient has bilateral disease. Now, then two tests. Barlow test. Barlow. Bahar low. Bahar low. So Barlow test means dislocation of the hip joint is easy. Ortolani test means relocation of the hip joint is also easy. Galeazzi sign. So you see, this side is normal, this side the patient has DDH. You make the child lie on the table, fold his knees. You will notice that the affected knee lies at a lower level. Affected knee lies at a lower level. Affected knee will lie at a lower level. Right? Investigation of choice: less than 6 months of choice, ultrasound. More than 6 months, the investigation of choice is MRI. Why ultrasound at less than 6 months? because MRI is unsafe. MRI is unsafe as it requires sedation. What is the X-ray going to show you? X-ray will show you broken Shenton arc. Broken Shenton arc. Now the Shenton arc is also broken in. You see, what is Shenton arc? Line drawn from the medial border. Line drawn from the medial border of femur, like this, to lower border of pubis, lower border of pubis. That is Shenton arc. Now Shenton arc is broken in other condition also, is broken in other condition. Femur fracture and dislocation of hip, dislocation of hip. Now treatment is to ensure wide abduction of the hip. Fine. 0 to 6 months. What is the treatment of choice? Treatment of choice is Pavlik harness. Pavlik harness. So this one is Pavlik harness. This one is Pavlik harness. Right? 6 to 18 months of choice. 6 to 18 months of choice, you will have to do surgery, open reduction, and then you will have to use bachelor cast. Bachelor cast. 18 to 36, you will have to do femoral osteotomy. 3 to 6 months, you will have to make the acetabulum round, that is acetabular augmentation. 6 to 10 years, no surgery, absolutely no surgery, because there is high risk, there is very high risk of avascular necrosis. More than 10 years, the treatment is THR, total hip replacement, right? Now, next topic here, small topic, Perthes disease. What is that? Spontaneous avascular necrosis. Spontaneous, that means no trauma. That means it is completely non-accidental necrosis of femur hip. The other name, coxa plana. What is the cause? Idiopathic. Male-female ratio. So that means it is very common in males. Now, this condition is usually painless. This condition is usually painless. Associated condition, clotting abnormality, protein C and S deficiency. That means there is increased tendency at clot formation. So blood clot formation can occur anywhere. Right? What do we get to see at the X-ray? So at the X-ray we get to see crescent sign. Crescent means like this, moon. Then we get to see gauge sign. Gauge sign. Then we get to see bite sign like this. Investigation of choice, MRI. Treatment. Usually no treatment is required because spontaneous revascularization occurs. If it does not occur, then we'll have to do fenestration, or ultimately, if nothing works, we'll have to do osteotomy. Fine. Now, in Perthes disease, 6 to 10 years is the common age group. Another disease which occurs in nearly similar 10 to 12 years age group is slipped capital femoral epiphysis. So this is common in adolescents, and this condition is painful. Most common association is with hypothyroidism, because hypothyroidism, it makes your patient obese. It makes your patient obese, right? So I told you that this condition is very, very painful. As compared to Perthes disease, this condition is extremely painful. What is important? Draman sign. So what is Draman sign? Obligatory, honi hi honi hai. Obligatory external rotation with flexion, with flexion, right? Now, the epiphysis slips away, just slips away. So this is similar to Salter-Harris type 1. Similar to Salter-Harris type 1, right? You see here, epiphysis, it has slipped away. Fine. Treatment is closed reduction and pinning. Closed reduction and pinning. Now, dislocation of the hip joint. So, three type of dislocation. First, posterior dislocation. It is most common, and it is common in car dashboard. It is common in car dashboard injuries. Clinical feature, flexion, right? Your patient will present to you with flexion, adduction, and internal rotation. You see, flexion, adduction, and internal rotation, and internal rotation. You'll not be able to palpate the femoral artery. You'll not be able to palpate the femoral artery. Treatment is closed reduction. No surgery is required. No surgery is required. Now, what are the complications? Complications are sciatic nerve injury and avascular necrosis. Anterior dislocation, it is common in bike injuries. Clinical features are flexion, abduction, and external rotation. Complication is injury to femoral artery, vein, and nerve. Femoral artery, vein, and nerve. Treatment is closed reduction. Closed reduction. Central dislocation. It is common in the patient who have got weak bones. For example, if your patient has osteomalacia, treatment is surgery. Then, two different fractures. Fractures around the neck of femur. So the first intertrochanteric fracture, greater trochanter and lesser trochanter. It is also called extracapsular fracture. Why? Because you see, this is the capsule. Let's say this is the capsule. So this fracture, it will occur outside the capsule. Whereas on the other hand, the intracapsular fracture, it will occur here. It will occur here. Inside the capsule. Inside the capsule. Right? Now, extracapsular fracture, it is common. Extracapsular fracture, it is common between 70 to 80. Whereas intracapsular fracture, it is common between 50 to 60 years of age. Now, treatment for extracapsular fracture is very, very simple. Treatment is either we use dynamic hip screw or intramedullary nail. This fracture, it heals rapidly. That is why malunion is common, right? Now, for intracapsular fracture, if your patient is old, now hemiarthroplasty is done if your patient does not have osteoarthritis, whereas total hip replacement is done if your patient has osteoarthritis. Problem is in the young people. Young people having recent fracture, treatment is surgery, immediate surgery. Young people having old fracture, young people having old fracture, right? There, what you will prefer? So there you will have to do 2-3 surgeries, right? For example, you can do McMurray osteotomy, Powell osteotomy, fine. You can do vascular graft, you can do vascular graft. The most common complication here is non-union. That's the difference between extracapsular fracture and intracapsular fracture. Now, I honestly and really like to be with you guys. So if you want, I can go for hours and hours and hours. But then of course, there are some limitation at my end. There are some limitations at your end. Fine. So Meduhub, is coming up with a lots and lots of new plans, right? Lots and lots of new ideas are coming up. So I believe that we will be in touch. We'll always be in touch, right? So wish you all the best for your upcoming exam. Fine. Do extremely well. Fine. Definitely, you'll score pretty decent rank, pretty decent score, right? And if you have any queries, I'm always available, right? So with this, I would like to end today's class. Right? Not many things to do, right? So do study, and then we'll come up with something else also near future, right? Wish you all the best. Looking forward to see you soon with beaming smiles that yes, I could clear the exam this time, right? All the best. Thank you so much. Good night.